I'm going to go ahead and press record. Okay, that's working. Okay. Hi there. I'm here today with Danielle Doyle, who is a double boarded anesthesiologist and pain doctor, and she has lots of experience in this area. She's an award winning professor and a Washingtonian top doctor. She spent her career administering and teaching anesthesia at tertiary care centers and level one trauma centers, providing diligent and compassionate anesthesia care for critically ill adult patients. She's a trailblazer in the field of ketamine care and chronic pain, having directed the George Washington University Pain Center and Ketamine Infusion Program, providing care to thousands of patients. She's currently the CEO of Cultured Therapeutics. She's also an advocate and she does work in health equity and ketamine care. And she's been featured on various platforms, including NBC News, Physician Weekly, Black and Neuro, TalkingDrugs.org, and the Daily Mail. She's recognized for her contributions to starting the first accredited pain fellowship in DC in liaising, how do you say that?
Liaising.
Liaising. Liaising with the Office of the Attending Physician on Capitol Hill to ensure the members of Congress, the Supreme Court, and the White House have excellent access to cutting edge anesthesia and pain care. She is She's also on multiple social media platforms, and I'll provide the links to those in the show notes. So let's go ahead and get started. Welcome. You've done so much.
Thank you. Thanks for having me on. And yeah, I wear many hats,
Yeah.
but my anesthesia hat is very near and dear to my heart because it's kind of, what I trained in and what I started being as a doctor.
So I wanted to start and just ask you a couple of questions that I hear from patients. So I think the two questions that I get asked most frequently about anesthesia is one, is it safe? And then two, about cognition and memory loss, right? So those are the big fears that a lot of my patients have. And I'm just wondering if you could speak to that at all.
Sure. So it's a really good question when patients are concerned about anesthesia safety, because anesthesia has come a really long way. So if you were raised in the 60s or 70s or raised by someone who was, raised in the 60s or 1960s or 70s, at that time, the risk of having something bad happen under anesthesia was about maybe 1 in 20,000, which isn't a super high risk, but it's magnitude safer now. So the risk of having something really bad happen under anesthesia is probably less than 1 in 200,000. So that would mean 200,000 people would have to receive an anesthesia for somebody to have a really, really bad outcome with it. So when you think about that, you can kind of compare it to ordinary things that we do. So when I talk to patients on the day of anesthesia and they're really nervous, I have a really short window to build trust and to kind of demystify and to kind of get some myths out of the way. So if you drove or someone drove you to the hospital or drove you anywhere, your risk of having something really bad happen in that car is about 1 in 107. So you are magnitude safer. You're magnitude safer, undergoing anesthesia than you are probably driving, than you are in the shower, your risk of having a slip and fall or something like that. But I understand that it feels really, really risky because you drive or you're driven every day or you shower every day. And that's completely normal. That's a normal cognitive bias. It's called a normalcy bias or a worst case scenario bias, where if something is not really familiar to you, it feels like really, really, really dangerous and you're really, really concerned. And that happens to me too. I've had general anesthesia and I'm an anesthesiologist and I was still feeling concerned. But it's magnitude safer. There are a lot of new advents in anesthesia in the last 30 to 40 years, which have made it safer. One of them is that we can monitor your oxygen levels continuously from the time you get into the operating room till the time you go home. So that decreases your risk by a lot. And the second thing is what we call end-tidal CO2. So basically, that means if we have to take over your breathing, we can be sure that that breathing tube is in the correct space within about 4 or 5 seconds. And if it's not, we can immediately correct it. And so that's why anesthesia now is now magnitudes times safer than it used to be in the past.
Thank you so much for that, super practical comparison, because I think that, does make you realize how very safe it is and how very unsafe driving is. Um,
Yes.
and also, I think the thing, I mean, just like you, I too am very nervous about anesthesia. Um, because I think it's such a, you're giving up control, right? You're in such a vulnerable position. And when I'm driving, if I'm in an accident, chances are, well, I mean, there's a 50% chance it's my fault. But it feels like you're in control, and it's just such a vulnerable position. So I think, your approach is just so lovely and reassuring.
Thank you. And it's normal. I like to tell people it's normal to be anxious. Sometimes it might be a little less, common for you to not be anxious before undergoing an anesthesia or a surgery, and that having questions and having anxiety, as anesthesiologists, we are prepared to deal with those things. And so we really want to know if you're feeling anxious or if you
Yeah.
have
I,
questions.
I frequently tell my patients that if they're not anxious, it makes me anxious, right? Because it's such a normal part of the process, right? And it's normal to be anxious before a procedure. What about memory loss? Because I think that's another fear that patients have too.
So risk of memory loss is another good question and a good concern. It's typically quite low. The risk can increase if you do have a history of an underlying dementia or cognitive disorder. And usually if you're a lot older. So in the elderly, with something that we study pretty frequently, the risk of having some cognitive dysfunction afterwards, though it tends to be, again, very, very rare. And if the anesthesiologist does know that you have some of those underlying conditions, there are some specific medications that perhaps we can avoid so
Mhm.
that we can get you as awake and alert as we can before you leave to go home. But
Yeah.
again, it's going to be pretty rare that you're going to have a permanent cognitive dysfunction after an anesthetic. That being said, you want to make sure that you let your anesthesiologist know about any medications you take for mood or for dementia. You want to let them know if you've had any problems with the oxygen levels in the past or with anesthesia in the past. You really want to have a really well-rounded conversation with your anesthesiologist.
Yeah. Yeah, sometimes I'll have patients who will, hold some information back because they think it's not pertinent, right, or relevant to what the anesthesiologist is doing. And so I think it's just so important to be as open as possible because it helps the anesthesiologist take better care of you, right? Even with respect to over-the-counter medications and drugs and alcohol, right? You want to be an open book.
Exactly. It's herbal supplements,
Mhm.
sometimes supplements, ginkgo, ginseng, things like that can increase risk for bleeding. And so we want to know, even if it's something that might not seem super important, that you take 10 milligrams of melatonin every night. Like just let us know.
Yeah, absolutely. So, what about anxiety? I mean, what do you recommend for kind of perioperative anxiety?
So I think the first step again is transparency between the surgeon, the anesthesiologist, and the patient about what's underlying the cause of the anxiety. Is it that you have concerns about the surgery? Are you scared about the anesthesia? Or is it that you have a baseline anxiety disorder? And depending on what the cause is, we can kind of direct care to help you. So if you have an underlying anxiety disorder or a mental health issue that's going to affect your anxiety levels, the anesthesiologist will want to know if you're on anti-anxiety medications. Now, every case is different. I will typically have patients take their anti-anxiety medicine in the morning with a small sip of water. And typically we'll also supplement, again, everything is case dependent, but we'll usually give an anxiety medicine before the patient heads back to the operating room. I tell patients to think of that, it's kind of like a Xanax, but it's in IV form. And for some people, it's gonna kind of kick in really soon. You're gonna feel kind of warm and relaxed. For some people, you may not experience it as much. And a lot of the anxiety that people have around surgery, there's not necessarily a chemical or a medical cure for it. It's a lot of times there's a people cure for it, there's a talking cure for it. So telling the patient what to expect before they get back to the operating room. So you can tell them, hey, we're going to go back to the operating room. It's going to be really cold and dry back there on purpose because we want to decrease your risk for infection. So I'm going to give you some warm blankets before. I'm going to have you scoot on over to the table, and it's a really narrow table. I promise you, you're not going to fall. We're going to take good care of you. Everybody feels like it's really small. And then I tell patients, you're going to feel like a NASCAR car. You're going to feel like a pit crew is around you doing a bunch of stuff at once. And that's because we will be. I said, that's completely normal too. And so just really letting patients know what's going to happen if that's something they're interested in. Some people say, I don't want to know,
Yeah.
and that's fine too. But kind of educating them on what's going to happen can really help too.
Yeah, it is such a foreign environment, right? And even though we spend all of our time there, I think sometimes we forget that it is new and strange and not warm and welcoming, right, to patients. And I totally agree with what you said. I think a lot of it's trust too, right? You have to trust your surgeon. You have to trust the team around you, trust the anesthesiologist. And especially for anesthesia, usually your relationship is quite short. And so you have to, create that trust in a pretty short time frame.
Exactly. And just know everybody on the team, the anesthesia team, the surgical team, the operating team, nursing staff, we're all there for you as the patient. We're there to make sure you get your surgery done, that your modesty and your dignity is respected, that your safety is respected, that what you have agreed to have done is what is done and nothing else. We're really there to support you. A lot of patients kind of come in and, I want them to feel that extra support. So, you don't have to apologize if you don't have your makeup on that day, or if you didn't shave, or you didn't put your lotion on and your legs are ashy. I get a lot of, especially women, a lot of patients apologizing. And
Yeah.
it's like, you don't have to apologize for anything today. We're here for you,
Yeah.
and we're here to respect you. And if anything looks like it's not going to support that happening, please know that I will be an advocate for making sure that things get back on track.
Yeah. Yeah, I agree with all of that. And especially the dignity and modesty part, right? I mean, as a urogynecologist, we're frequently, working on your down there area, right? And so everyone feels particularly vulnerable, in that position, especially with anesthesia, right? So I think recognizing that everyone on the team is interested in preserving your modesty to the best of our ability is really important.
Yes, I agree. I
Yeah.
agree. And it always feels different when you're the person, as I say, on the table, you're the person, and so I understand that.
Yeah. No, I mean, I agree with that, right? I mean, I frequently say that I think I learn more when I am the patient or the mother of the patient. I mean, you just learn, or it reminds you of all of the little things, right? I mean, as I start embarrassing about my dry legs or apologizing about my dry legs, it's funny the things that we kind of instinctively do, right? And it's all, just a sign of being a little bit nervous and anxious, right? So what about the two other things that I really wanted to explore with you is nausea and pain control after surgery. So, nausea is just so common and some women are just so prone to it. So what kind of tricks do you have to minimize nausea around the time of surgery?
So nausea or postoperative nausea and vomiting, it's really an element or thing around anesthesia that we spend a lot of time
Mhm.
focusing on. There are thousands of articles on how do we prevent postoperative nausea and vomiting? I think the first thing, again, is going back to the history. We want to know if you've had anesthesia before and you've had nausea and vomiting. For us as anesthesiologists, that's kind of putting off alarm bells for us. So knowing that can be very empowering for us coming up with your anesthesia plan. We also want to know if you have a history of, say, motion sickness, if you have a history of, chronic stomach issues, IBS, any cyclical vomiting syndromes, anything like that that might increase your risk. So if I do know that a patient is at risk for postoperative nausea and vomiting, the first thing that we can do for that starts at home. So a lot of times before surgery, we tell patients, okay, nothing by mouth after midnight. And a lot of times that turns into the patient has not hydrated since dinner time the night before, and then is coming in for surgery, say at lunchtime the next day. And so we have those eating and drinking rules in place to decrease the risk of someone kind of throwing up during anesthesia. But your risk for nausea and vomiting can really go up if you get really dehydrated. So it's okay to actually have clear liquids up to 2 hours before you undergo a general anesthesia. And we usually don't promote that very much as anesthesiologists because it really has to be a clear liquid. So you can't come in drinking a milkshake or a green smoothie, but having a lot of hydrating the evening before with some Gatorade, with water, even waking up if your surgery's at 1 o'clock in the afternoon, waking up and having water or apple juice, some sort of clear liquid that can go a long way towards helping with making sure you're not dehydrated. So that can help us get the IV in a little faster. And that can also help decrease your risk for postoperative nausea and vomiting. If you have a really serious history of that, there are special anesthesia techniques that we can use. A lot of the postoperative nausea and vomiting is often blamed on our gases. So we use anesthesia gases to help patients stay asleep during surgery. And so those can be kind of our special gases or something called nitrous. So if I know the patient has a history, I can concoct a special anesthesia that's just using medicines in the IV mainly, and that can decrease your risk as well. For some patients, we may also put a little seasickness scopolamine patch behind your ear, and that can help if we put that on before surgery. Sometimes a small amount of injected steroid can help as well to decrease your risk as well too.
Yeah. You're a step ahead of me because I was going to ask you to talk about clear liquids because I think that becomes so confusing for patients, right? That apple juice is okay, orange juice is not okay, black coffee is okay. The minute you put cream in it, it is not a clear liquid anymore, right? And so, I mean, I think that's one of the reasons that we don't often promote drinking clear liquids before surgery, just because it frequently is so confusing for people.
It can be, and if I was not an anesthesiologist, I would not understand it at all. But basically, when things have little particles in it,
Yep.
or if they have protein in it, like with milk or almond milk, it takes longer for your stomach to digest it. So it's sitting in your stomach and it increases the risk that you might throw it up, versus
Yeah.
a clear liquid is pretty much right in the stomach and passes right on by.
Yeah.
And I have a favorite story. I was helping to give anesthesia for a baby, and the mom came in and she's kind of feeding the baby the bottle and finishing up. And, we said, oh, well, we might have to wait a little while because we understand the baby's hungry, but the baby just had milk. And she said, no, it's fine. They peed it out already. I just changed the diaper. And so it kind of is like a common sense thing. You would think like, okay, yeah, in, out, that makes sense. But we're really talking about the physiology of your stomach.
Yeah. Yeah. Yeah, I talk a lot about it before surgery, right? And usually, just reminding people that orange juice is bad and creamer and milk are bad. Just because I think those are the most common things that we see. But you're right, those changes that we've made over the last, several years, I think, make the surgical process much more comfortable for patients too, right? Because they're not essentially fasting before the procedure or surgery, which is really, much nicer for patients. And then, once you figure out the anesthesia protocol, right, then you kind of know what to do for subsequent surgeries. So it's always so nice once you figure out that blueprint for a patient and then you can just use it. I mean, we like to redo things when we know that they work, right? So if you had a perfect anesthesia, it's always great to tell your next anesthesiologist that so they can look at it and make sure they're following that blueprint.
Exactly. That's my favorite cheat sheet. If someone is coming back and they've already had anesthesia there, that's just like pressing the easy button. I say, how did it go? It went great. I said, okay, I'm going to
Yeah.
pretty much do what you had last time.
Yeah, I mean, I agree with that. Why not repeat it, right? When someone has kind of figured it out, the chance of it's just as easy to get it wrong as make it better. So let's use what worked before. So what about pain? What are your recommendations for optimizing pain after
So I
surgery?
have a lot of ideas about pain. I'm an anesthesiologist and a pain doctor. So it's not unusual if patients have chronic pain issues that those are the cases where surgeons may request me because they might want the patient to see me afterwards. And again, I think it comes back to just having a really good history established. So as an anesthesiologist, I want to know, do you have a history of chronic pain? Are you on any chronic pain medications? If you've had surgery or injuries before, what has worked for pain? What have you had side effects to? Are there certain substances perhaps you don't want to be exposed to because of your particular history? But by and large, we've made a lot of advances in terms of perioperative pain management or pain around the time of an operation or an anesthetic. So a lot of times what we'll do now is we can give a little Tylenol or a little oral pain medication before surgery to kind of preemptively stop the pain from happening. During the surgery itself, we can or cannot give some additional IV pain medications. And then after the surgery, you have a discussion with your surgeon about what pain medications might be appropriate. I think anticipation and pre-planning is really important in managing expectations. So if there's going to be a few days that you're going to have a lot of discomfort and then it's going to gradually get better, it's really good for the patient to know that up front. So so it decreases that fear, because when you combine fear plus anxiety plus the unknown, it can really snowball out of control sometimes. So knowing that I'm going to be uncomfortable for 2 days and it should gradually get better can set up a game plan between the surgeon, the anesthesiologist, and the patient.
Yeah, I totally agree with you, right? I think the expectation is so important and understanding where the pain is, right? Is it on your abdominal wall? Is it, really your rectus muscles? Every time you cough, every time you sit up, that's what's going to hurt? Or, is it deep in the pelvis? I think that really, knowing where the pain is and what things might flare it as you go forward, right? That first bowel movement might make things worse. All of those things I think are really important for patients to understand. I personally like to um, tell patients that it's going to be a little bit more painful than I think it is, because then I think everybody is pleasantly surprised afterwards, right? I mean, no one ever really minds if it's better than they expected, but when it's the other way, I think that creates a lot of fear, right? Because there's always that worry that something is wrong, right? Because frequently it's your first surgery or your first pelvic surgery, and it all just feels a little different for you.
Yeah. And I also definitely want to know if the patient has a chronic area of pain. So if they have chronic neck pain, if they have arthritis in a particular joint, if they have chronic migraines, if there's, chronic facial pain, jaw pain, all of those things are important to let your surgeon and your operating team know, because we can position your body in a way to accommodate for those things. We can change our medicines to accommodate for your particular pain areas. So, we want to know if you have fibromyalgia. We want to know if you have diabetic nerve pain, if you have arthritis in your neck, if your back usually hurts. All of those things can be really helpful in coming up with a plan.
Yeah. Down to sometimes I'll position patients while they're awake, right? I mean, if someone has really painful hips and, we need to put you in stirrups, sometimes I'll position you while you're awake so you can say, hey, that's uncomfortable for me, and we can find a better position. Because once you have anesthesia, you can't give me that feedback, right? And you would be in that position for a period of time, which is so different than sleeping, right? You can move and adjust when you're sleeping, but with anesthesia, you're in one position, and if you have a little pain going into it, poor positioning can absolutely make it worse. Can you speak to the pain experience that patients with chronic pain have to have after a surgery, right? If you have that chronic pain and then you go into something where you have acute pain, right, from a surgery or procedure, what that experience is like for those patients? Because I think it's,
Unfortunately, sometimes it could be a difficult experience. And part of that is just the chronic pain itself. And then
yeah,
part of that is some of the unfortunate gaps in care and knowledge that we have in treating patients with chronic pain. So, a lot of times we ask about what's your baseline pain level? Where is your baseline pain in your body? If you're taking, chronic pain medications like chronic opioid therapies or things like that, it can be a little harder or a little more complex to get your optimal pain relief afterwards. But it doesn't mean that it's an impossible thing. So we can certainly put techniques in place to set you up for more success postoperatively.
yeah. Yeah, I mean, I think those patients usually have more postoperative pain, or in my experience, they have more postoperative pain, right? And I think it's important for them to know that ahead of surgery, and just know that if things aren't as smooth as we would like afterwards, right, that we'll work together to optimize things afterwards.
Exactly. And it can be challenging. But I think knowing that information beforehand, knowing that they have chronic pain, you don't have to be ashamed. No one is going to assume that you're, quote unquote, seeking drugs or exaggerating or anything like that. Like the first step to relief is belief. We believe you.
Yeah.
We understand what you've been going through is difficult, and we're going to put strategies in place to help you. And if you ever feel like that's not happening, we want to know so we can make it better.
I've never heard that before. I think I'm gonna start using that. The first step to relief is belief. I
Yeah.
mean,
Unfortunately, yeah.
go ahead.
Fortunately, a lot of patients with chronic pain, it's sometimes they feel like they're not being believed or they are not being believed. So it's
It,
an issue.
Yeah, I mean, I think as physicians, right, we like the things that we understand and the things that we can fix, right? And sometimes pain is elusive and it's difficult and frustrating for everyone. Uh, Above all, frustrating for the patient, right? But can just be hard to manage. What about opioids? Because I have a lot of patients who are really afraid of opioids and oxycodone. Do you want to just speak to how we're really moving away from that and using a lot of narcotics and prescribing narcotics after surgery? I mean, the amount of narcotics that we give patients these days is so much less than ever before. But I feel like we're doing a better job of managing pain while we're decreasing narcotic use.
Yes. So compared to maybe 10 or 15 years ago, the amount of opioids used in the perioperative space has really decreased. And some, cases, people try to really minimize the amount that's given. Some patients may still need a small amount of that. And I think having a frank discussion between the doctor and the patient is again very helpful when they've studied it. And or sometimes when I get called, we'll talk with patients and say, hey, the average patient after this sort of procedure maybe needs 3 to 5 tablets. And then after that, they don't really use much more than that. How do you think about that? Do you think that was an adequate amount? And most patients would say, yeah, that's fine. And realize that opioids, your risk for, say, an opioid use disorder or some sort of addiction or something like that happening has a lot to do with, risk factors such as family history of those things, any mental health conditions, a history of adverse childhood events, things like that can increase your risk for that. So if you do need one for a very short period of time, if you have a lot of those risk factors, feel free to talk with your team and say, I have a family history of this. I have a personal history of this. What do you think might be the best, plan for me? But in general, the consensus is to use a lot less opioids. I think there's probably a sweet spot in that there's probably a small amount we can use and have available. But it's not like back in the day, like 15 years ago, where you would have a tooth pulled and go home with like a huge bottle of an opioid with many, many tablets. But I think we can find that sweet spot with patients and say, hey, you may not need it, or you may need, a little bit. And if we are going to give it to you, we're going to give you an emergency medicine to go along with it. And we're going to give you instructions on how to get rid of this medicine if you have it left over in your house, how to safely dispose of it.
Yeah. Yeah, thanks for that. I agree with all of that. And it is always a conversation, and there is a sweet spot. Sometimes we give too few. We used to always give too many, and sometimes we have to reevaluate that. How much narcotic to give after a surgery is always a guess. And sometimes you have to reevaluate it to get to that sweet spot. And those conversations, I think, are always important because if there is an increase in pain, sometimes that means something else is going on and we need to evaluate it. And those shouldn't be shameful, conversations as you're moving on through surgery or past surgery. Um, and I think the common thread in kind of everything you've said is, just how important the educational piece is and the conversation and the relationship between physician and patient. So thank you for that, because I think that, we don't emphasize those things enough these days. And in the end, I think it is that relationship that is so very, very important.
Absolutely, I agree. And I really advocate for, the things that could be put in place to provide more time and more resources for physicians and medical teams to have that sort of interaction with patients, because there are a lot of pressures that are kind of veering away from that. And that is such an important piece of medical care and healing.
Yeah, yeah, I really agree with that. And I do think we're being pushed to move away from that, but I think that, that relationship and the time is really what helps patients to heal and makes the job so much more meaningful for us, right? To form that relationship and really help someone through everything they're going through.
Absolutely, I agree.
Yeah. It's an interesting time in medicine, isn't it?
It is. It is. And we're seeing a lot of, different changes that some of them have been accelerated since 2020 and, in hospital medicine and outpatient medicine. And I think it will be interesting to see where that goes. And I encourage your audience and your patients to advocate for themselves, for their medical teams, so that they can really get the care that they deserve.
Yeah, I agree. And I think that's a hard thing to do sometime, right? But saying, hey, I need a little bit more information. I don't understand this, or I'm afraid of this. I think that is important. And, if you're feeling rushed through something, it's okay to say, I need more time.
Absolutely. I agree.
So, although, sometimes it's a little bit uncomfortable. So, anything else? Are there any parting pearls that you have?
I guess, as I said, it would just be, have a really good conversation with your anesthesiologist and with your surgeon if you're anxious or nervous. And, I really talk about like hydration, prior to anesthesia, and having really an adequate set of expectations in place for what's going to happen. Because when we look at things like sports psychology or things like that, really having a good idea of what's going to happen and about when it should happen can, as you said, it can make you feel in control when you're driving, right? So you can feel in control when you have information.
Yeah. Yeah. Thank you for that. Well, thanks so much for your time. This has been great. I really appreciate you, and hopefully we'll do this again soon.
Absolutely. Thank you.
Um,